Hello, thank you for joining MSDC for its Washington Healthcare WOW series, where MSDC digs into issues that impact physicians in the district personally and professionally. I'm pleased today to be speaking about prior authorization, and we have with us today both Emily Carroll from the American Medical Association and Dr. Angus Worthing, a DC rheumatologist who is part of MSDC's Advocacy Committee. We're speaking about prior authorization today because 2022 actually marks the 10-year anniversary of the Medical Society's efforts to legislatively fix prior authorization. This is a long battle that we've been working on, and we are now glad to be partnering with the American Medical Association and other constituents across the region to be able to have a 10th year anniversary victory on prior authorization. That I'll let our panelists introduce themselves and move forward from there. Thank you. Dr. Worthing?
Hi, thanks. I'm Angus Worthing. I'm a rheumatologist, as Pia Duria said, and I work at Arthritis and Rheumatism Associates in downtown DC and K Street and in Chevy Chase. I also am serving right now on the board of directors for the American College of Rheumatology and also a nonprofit called ATAP that sort of works in this space, Alliance for Transparent and Affordable Prescriptions. And I appreciate the invite. Thanks.
I'm Emily Carroll. I'm with the American Medical Association, and I'm in our state advocacy department. So work with state medical associations and national medical specialties across the country, implementing reforms that are on the top of their agendas. My specific areas kind of focus on commercial payer reforms and healthcare reforms or health insurance reforms. So prior authorization always rises to the top of that list every year. Glad to be with you. And I think I will probably just get started and dive right into a few slides. I just wanted, this is probably the wrong audience to tell about how important it is to address prior authorization and implement some reforms, but I'll just quickly go through a survey that we conduct every year at the American Medical Association on the impact of prior authorization on patients and physicians. And as you can see from some of these graphs and charts, prior authorization impacts patient care. This year, 94% of physicians reported care delays as a result of prior authorization. 79% reported that prior authorization can sometimes lead to treatment abandonment. And 90% reported that prior authorization has a negative impact on clinical outcomes. Next slide, and this slide always gets me. 30% of physicians report that prior authorization has led to a serious adverse event for their patients, and 21% reported that prior authorization has led to a patient's hospitalization. In addition to the harmful impact on patients, we certainly know that prior authorization wastes resources, time, money in the physician's practice. On average, physicians physicians complete 40 prior authorizations per week. That's per physician. 40% of physicians report that they have staff that exclusively works on prior authorization in their offices. These prior authorizations take up 16 hours a week, so that's 2 full business days that are dedicated to prior authorization in the practices. And 85% of physicians reported that the burden associated with prior authorization is extremely high. So given that, what has the AMA been doing with our partners on prior authorization? First, a couple, or maybe like 5 years ago at this point, every time is lost meaning. We came together with a number of stakeholders, not just physician organizations, but other groups that are impacted by prior authorization. So the pharmacists, the hospitals, patient organizations, MGMA, and we created a set of 21 principles that we thought were imperative when you reform of prior authorization. So the sort of underlying assumption, and I think this is really important when we approach legislators and regulators with regard to our prior authorization priorities, is that we're not looking to get rid of prior authorization. I mean, I think that is certainly, the dream of every physician and patient out there, but that's not sort of feasible in the legislative and regulatory arena. So we understand that prior authorization is going to exist, but we need to streamline it. We need to make it appropriate, and we need to make it so that it's not the burden that it is. So we came up with this group. We came up with 21 principles, and they're grouped into 5 categories: clinical validity, continuity of care, transparency and fairness, timely access and administrative efficiency, and alternatives and exemptions. And these principles really have served as the basis for our reform efforts over the last several years. They also led to an effort in 2018, which we've called the consensus statement on improving the prior authorization process. And this is where we came together with some of the payer organizations, AHIP and Blue Cross Blue Shield, to sort of address what may be the low-hanging fruit in prior authorization reform. And we collectively came up with kind of 5 buckets that the payers and the other organizations involved kind of agreed upon. And you can see those 5 issues or 5 buckets right there: selective requirement to reduce the volume of prior authorization, regular review of services and drugs requiring authorization, improved transparency and communication, protections for continuity of care, and automation. And we have really taken this consensus statement to legislators, regulators, other stakeholders, and employers, and said, hey, this is what these organizations came up with and believed was doable. And so again, this has also served as the basis for a lot of our reform efforts. Unfortunately, that consensus statement has not led to consensus reform efforts. We still continue, as you all know, to battle out some of these reforms at every level, including in the state legislatures. We have created at the AMA a model bill that uses a lot of those reform principles and the principles contained in the consensus statement. And we work with state medical associations across the country every year to push for some of those reforms. On the side here, you can see there's a couple of the reforms that are included in our model bill, including kind of quick response times. So we believe there should always be 24-hour turnaround for urgent care, 48 hours for non-urgent care or sooner. We think that anytime there's an adverse determination made, it should be made by a physician licensed in the state and of the same or similar specialty. We can't have folks that may not be qualified to provide this care making determinations about what's appropriate and medically necessary for patients. It is the practice of medicine in a lot of ways. We would prohibit retroactive coverage denials if care is authorized. So you shouldn't have to get a prior authorization and then get a denial after that. We think authorization should always be valid for at least a year, regardless of dose changes. And for those with chronic conditions, we think there should just be a standing prior authorization for the length of the treatment. People with chronic conditions shouldn't have to be going back every couple months or even every couple of years to get authorization for the same service for the same condition. A plan should honor a patient's prior authorization for at least 60 days. We also think that there should be public reporting of prior authorization statistics, and a lot of states have been able to enact this despite a lot of pushback from the payers. We need to know kind of what's going on behind the curtain. What services are getting prior auth the most? What are our approval rates? What are the denials? Are there certain specialties that are being targeted by certain prior authorization rules? Wait times, all these things we need to be able to sort of better understand the process so that we can target our reform as appropriate. Gold carding or prior authorization exemptions. This has been part of our sort of volume reduction talking point and effort for a really long time. We don't think that if you're getting approvals, 90% of the time that you should have to keep applying for prior authorization for that service over and over. And then we have put in an effort around automation and the use of electronic prior authorization. This really goes to making the process easier when it is used. And a lot of states have been able to adopt those reforms. You can see in this map, last year, we had 3 states that implemented really, really broad prior authorization reforms. Georgia was able enact a lot of the reforms that are that I just listed, and used passed a bill that was based on our model bill. Illinois similarly did the same, and then Texas really uniquely was able to implement a gold carding law last year, where if physicians are meeting approval rates of 90% for services or drugs, they automatically get approved for that prior authorization, and they don't have to go through the process. So that was a really exciting development. There's only been a handful or a couple of other states that have even come close to getting those sorts of reforms in place. So a lot of states are looking to Texas and that law and attempting to model their laws this year on that new law. This year, we do have a ton of states that are looking at prior authorization reforms. Again, I think there's about 5 states looking at gold carding laws that have already been introduced, and a couple of others that are looking to introduce those. And we have several other states that are looking at broader reforms as well. There's a lot of focus recently on the treatment of folks with chronic conditions and how we can make prior authorization, as I mentioned, sort of standing and not repetitive for them, so that there's not this continual back and forth to get those treatments approved. And we have a lot of interest as well in looking at sort of the criteria around prior authorization and whether that could be standardized, so that you're not having to navigate different criteria for different payers. So I already went through those reform proposals, and I will just say that there has yet to be a state law passed that hasn't been a coalition effort. This is an issue that impacts tons of different stakeholders, pharmacists, hospitals, and importantly, patient organizations. And every state that has been able to pass broad reform has done it through a coalition effort. Michigan and Illinois are 2 of the most recent sort of that come to mind, and they actually created websites and kind of formalized their coalition efforts. And it really, I think, has been really impactful as they go to the legislatures to promote their cause. It's just, I can't stress enough how critical it is that this becomes a coalition effort. And finally, I'll just mention that the AMA does have a website, fixpriorauth.org, or a microsite, and a lot of our resources are posted there. And there's also an opportunity for story collection, both from physicians and other providers as well as patients. So there's a lot of heartbreaking stories on there about the impact of prior authorization on patient care. And we really just encourage folks to go to that website, share their stories, and then look around and pull down our resources. Like I said, we have our model legislation that's available. We have a state law chart that shows what state actions have been taken over the last several years and what states have been able to do. We have a lot of media, media stories that have come out over the last couple of years that really do a good job of communicating the impact of prior authorization. So lots of good stuff on that website that is accessible for all. And I will just leave it there. I'm always available for contact and to talk more about prior authorization and other administrative simplification efforts. But I'll end it there.
Well, thanks, Emily. I'll jump in now, and then happy to also talk about more specific topics as they come up. But so again, I practice rheumatology in DC, and I wanted to provide a little bit of context about what prior authorization means to us and our patients and our clinic, running an efficient clinic. A little bit about, I also want to talk about how this is part of a bigger context of drug pricing reform, and specifically in rheumatology, but it makes sense to any specialty. And then also talk about fixes a little bit. And it's really exciting to hear about Texas. I think Texas Medical Association, as part of the coalition of AMA, is one of the stronger states. And so nice to take some lessons from them. So in rheumatology, we, as a lot of the folks in the audience know, we practice with patients, take care of patients who have rheumatoid arthritis and other inflammatory diseases. We use what are called specialty drugs, or biologics and targeted molecules that tend to be expensive. And often when we prescribe patients are either taking them at home or they might come into the office. So we have an infusion center. And to give you a sense of the scope of what prior authorization means to us and our patients, there's 25 doctors in my practice over 7 locations around the metro area. We have about 250 employees total, and that includes physical therapy and nursing and x-ray, et cetera. But 22 of them work on prior authorization, which is in line with the numbers you were saying, Emily, that 4 people work full-time only on outpatient prescriptions, and 18 people work mostly, but also on other administrative duties for supporting infusion drugs that patients will get. So it obviously is not the case that the patient's treatment begins right after diagnosis and prescription, but obviously days, and I've been telling people sometimes a month after we start the process. So it does make sense to me when I see, it's consistent with my experience when I see estimates that billions, $20 or $30 billion in the United States are spent. And as you were saying, 2 full-time days of prior authorization work for physicians. In the bigger context of drug pricing, what does this mean for drug pricing reform? I have learned about the sort of intermediaries in prior authorization, the pharmacy benefit management companies who create the formularies of what's covered and what's not covered on behalf of insurance companies. And now they own each other. So they're sort of the same thing. But when I prescribe a specific biologic drug for my patient, and that goes up for prior authorization before it gets covered, when a denial occurs, when the drug is not approved, that's usually part of step therapy, which a lot of folks on the Zoom know. What step therapy is, I'd encourage people to think about this as how PBMs run, how the insurance company runs an auction, and it sort of enforces an auction. So if a drug company has a new drug coming to market, or an old drug for that matter, and it's a new year, a new formulary, they're going to want to get coverage, especially when it's a rheumatology drug costing lots of money, has to be covered in order to get sold in the United States. And so there's an auction every year or so for the preferred or the covered drugs in rheumatoid arthritis and other diseases. And the drug that can afford a larger rebate payment back to the PBM or the insurance company tends to get the higher spot or the more approved spot, and they can simply pass that higher rebate payment, which is a kickback. They can pass that cost payer, which can be government and Medicare, taxpayers, businesses, and also doctors, folks like us purchasing insurance for our staff. So the higher the rebate, the higher the price of the drug, which means paradoxically, more expensive drugs are covered frequently in the specialty drug space than less expensive drugs. And I've seen that in my practice. Drugs that are known to be less expensive are not covered. Also, we see that with biosimilars, where long-acting insulin that just went, not generic, but biosimilar, sort of like a generic biologic, had to come up with a brand version of itself in order to placate this rebate system that goes to PBM. So prior authorization is all of the things that Emily said: waste, lack of transparency, delay for patients, but it also enforces this ratcheting up of drug prices in the US. What are we doing to fix it? As was said earlier by Pia, it's now the 10th anniversary of a thing you don't want to have a 10th anniversary for, which is trying to introduce legislation in the DC Council. But we will be working with a champion, my personal council member and a person who's been a champion for health reform in the district, Council Member Mary Che, and we're talking with her office to implement the exact things that the consensus statement came up with. So transparency, reduction of some paperwork, both by taking out duplicative questions, unnecessary questions, things that are not pertinent to the drug in question. I would also add that business ethics are a part of this. So we've been asked by CVS Caremark to come up with a percentage improvement in disease activity in order to maintain coverage for drugs. And this is something that's actually a high quality, should be a high quality piece of data that's often purchased from registries of data. And through prior authorization, the companies are forcing physicians and our staff to do work to provide that data. So I don't think that's ethical. We are very excited about gold carding. Since I think a lot of us feel like most of our prior auths are covered, that we should all probably feel like we need a gold card. I know I do, and the patients I'm caring for probably wish I had a gold card. And we need to reduce that burden, as I said, with a huge chunk of employees that I would much rather focus on patient care, calling patients and talking about how their medications are working instead of calling their insurance company on their behalf to get authorization. A couple of questions I had, and I'm kind of curious about how a discussion would go. That consensus statement that AMA worked with, and I know lots of specialty organizations, and you were probably a big part of that. But all the stakeholders seem to be in agreement. You know, the insurance company AHIP is on there. So does that mean that prior auth reform is common sense reform that should be agreed upon by all stakeholders and maybe bipartisan in places where there's city councils or state legislatures? Emily, do you think are you seeing like both sides of the aisle kind of come together on this kind of thing?
I think it is not a partisan issue necessarily, right? I mean, I think that is not something we necessarily see in the state legislatures. But unfortunately, despite the consensus statement, despite the agreements there, it is not something that has presented itself as a consensus when it comes to actually passing legislation. I think we're still seeing a significant amount of pushback from the plans as these bills come to the state legislatures or federally as well. And that, I think, the question is, when the rubber meets the road, will the plans really be able to support these changes? And unfortunately, the answer is no. So I think, each state is different. Each state has had different levels of response from the payer groups in those states, but generally, we are not seeing support for reforms that reflect the consensus statement when it comes to actually implementing the legislation.
That's too bad. Unfortunately, unfortunate and maybe not surprising, but still the work needs to get done. And what about coalitions? You mentioned everything we do in the office and in advocacy is around the patient. Obviously, a lot more voters who are patients, obviously, than medical professionals. Are there certain groups or disease state advocacy groups that tend to be most vocal? And I'm guessing, physicians are a trusted source, I hope, for our councils and our legislative bodies. So I encourage everybody to raise their voice to their representatives. But who are you seeing as popular in these coalitions?
Well, I mean, they are broad coalitions because nearly every patient group, every disease group has been impacted by prior authorization, right? Everybody has a story and they're never good. The original reform principles were drafted with the help of the Arthritis Foundation, and they've just been a huge instrumental partner in passing some of these prior auth and step therapy reforms. They're great to work with. But cancer organizations, MS organization, I mean, you name it, and at some state level, they've been engaged on these issues. And I think the great thing is, as states embark on on these efforts, in some ways, the coalitions might already exist, right? The national organization may have already worked with their state chapters on these coalition efforts. So you're not necessarily even reinventing the wheel now, right? those conversations may have already been had, the stories may have been collected. So there are really great opportunities to quickly pull these coalitions together and to get sort of that momentum behind legislation fairly rapidly.
Yeah, that's a great discussion. I'm curious if you've seen, now that legislatures are coming out of the pandemic, a lot of in-person committee hearings or meetings, and some virtual, but we're noticing that as people come back to the doctor, there are diseases presenting later. What we thought was happening during the pandemic, when people weren't getting their cancer screenings, for example, or other medical care, that this would happen. It would seem to me, and I was talking with Pia about this earlier, that prior auth reform, once people are coming into the doctor, getting them on their medication quicker, eliminating this barrier, would be more urgent now as we're seeing people come back after the initial surges of the pandemic. Are you thinking that that's a tool that we can use to advance this in legislatures?
Absolutely. I mean, I would say there is a greater need for urgency in getting folks the services they need. And there's also a lot of practices are stretched thin, right? So to be spending time on prior authorizations when it could be spent on patient care is even more important to recognize during and post-pandemic, I think. There were a lot of reforms that happened sort of in the emergency of the pandemic that either governors signed executive orders around, or departments of insurance implemented really quickly, like no prior authorizations on certain types of care. They didn't want to expose patients to having to wait at the pharmacy while they got the prior authorization, right, and waited for that, or they didn't want folks to have to come into their office to get to physician offices unnecessarily to get prior authorizations, or there were a lot of lifting of prior authorizations, transferring folks from acute care to post-acute care, things, to open up hospital beds. There were common sense reforms that happened really quickly during the pandemic that I think logically should be, continued. And I think it's important to recognize that the sky didn't fall. Prescribers weren't going crazy because they could during the pandemic. I mean, these are letting physicians and other providers determine appropriate patient care is the right way to go. We recognized that during the pandemic, and that kind of thought should be continued.
Gotcha. Well, I had no more points or questions, but I'm really glad we had this discussion, and I look forward to working with the society and the council on getting stuff done here in DC. But I'll kick it back to Pia Duria.
Okay, thank you. And thank you both, Dr. Worthing and Emily, for your presentation, your discussion on prior authorization. This is, as I mentioned, it's a project, it's an issue that we've been working on for a long time. It's part of our advocacy priorities that our board is addressing, and we appreciate your insight. For anyone, and yours, Dr. Worthing, for anyone who has any other questions, we do have in the future, we can put you in contact with Ms. Carroll. She had her information up there on the website, and with Dr. Worthing. And we encourage anyone and everyone to put these ideas into practice to help us build a coalition to help fix prior authorization and move the ball forward on this priority issue. Thank you.
Thank you.
Thanks.